Great, everybody. Wow, it is very hard to cover all of IP in such a short morning. But our last IP talk of the morning is coming up next. This is Dr. Keys, who is going to present on interventional bronchoscopy in COPD. Dr. Keys?
Great, thanks very much. We'll be discussing some of the interventional aspects for treatment of COPD. Later in the afternoon, Walter O'Donnell will be talking about some of the medical advances. I'll just focus on the interventional aspects here. There we go. No relevant disclosures. So I wanted to start with a real life case example. This is a patient I saw probably about 1.5 years, 2 years ago now. He's 68 years old, was 68 years old at the time, had obvious COPD with airflow obstruction. You can see the spirometry and lung volumes that were available to me at the time, was referred for possible bronchoscopic lung volume reduction. He did have a longer history of asthma, was very compliant with medical therapy, and had quit smoking a number of years before he had come to see me, was short of breath to about 100 feet. So this is his chest x-ray at the time, and you can see some predilection for lower lobe predominant emphysema. He had been tested for alpha-1 antitrypsin and did not have a deficiency there. So I don't want to belabor the point of the physiology for the development of emphysema, but I think it is important to touch upon it a little bit because that's really where the technology and the current studies in the technology have arisen. What we're really talking about is the chronic changes over time that can occur with the emphysematous phenotype for COPD, where you get a lot of lung trapping that will eventually lead to hyperinflation, and then as a result can affect and weaken the inspiratory muscles. They're overstretched, causing increased work of breathing. So we're trying to essentially temporize all of that. The important things we don't want to let go of, the mainstays or the potential modifiable traits for emphysema and COPD. And so regardless of what type of intervention or surgery we're recommending, the important things are compliance to therapy and pulmonary rehab, and pulmonary rehab. Optimizing nutrition, and then obviously oxygen therapy if it's warranted. These are some of the interventions, and I do think it's helpful to have a bronchoscopic lung volume program at a center, or at least have access to the referrals for other types of surgical treatments, because there are patients who I will evaluate for bronchoscopic lung volume reduction and really determine that they're better suited for a surgical bulectomy or even lung transplant. Oftentimes, a lot of these evaluations are also done in parallel. So there are patients, for example, who are sent for lung transplant evaluation if they're determined to be a little bit on the earlier side for that listing. Then sometimes we will provide endobronchial valves as a bridge to that therapy. So I wanted to touch upon the surgical trials because I think that's really where the excitement about bronchoscopic lung volume reduction came about. The NET trial, I'm sure many of us are very familiar with it, had a number of patients enrolled in a treatment trial where they treated the bilateral upper lobes by surgery and essentially did a reduction in order to see if it would improve exercise capacity, lung function. Indeed, it did. But what they really determined, if you look at the Kaplan-Meier curve over to the right, the patients who really benefited the most were those who had upper lobe predominance and had a fairly low exercise capacity. And what are we talking about? Low exercise capacity. That was about 25 watts for women, which is about walking at a slow pace or some determined stretching. Men, it was about 40 watts. Those are the patients that really benefited. Subgroups of patients who potentially had higher exercise capacity, but the lung function was just as bad, tended to not do quite as well. The mortality rate, which I think probably caused the excitement over the procedure to wane a little bit. And by 2007, there was an opinion article thinking that the surgical lung volume reduction procedure was potentially dead because the original excitement had really waned by that time. I think there is some pickup of some interest in a multidisciplinary comprehensive program because I think there is value, and clearly you can see here by the study. The other downside to it, in addition to the mortality rate, was that a vast majority of the patients ended up with air leaks, and 12% of them were actually in the hospital longer than 30 days for that air leak. So as a result, people started looking at whether or not there was a way to do this endobronchially by a bronchoscope and to achieve similar results. So the endobronchial valve in the US was approved in 2018. The technology behind it really focuses on a unidirectional valve, and there are two companies that are producing it, achieve that in slightly different manners, but essentially it's the same idea where you're trying to essentially evacuate the air from your target lobe in order to reduce the hyperinflation. And when a patient inhales, it won't allow the air to go back in, but any mucus or air can exit as the patient exhales. This, as a result, will hopefully result in increased elastic recoil and decreased dead space. This is the timeline, and it really happened quite rapidly. The initial studies looking at it were really in the early aughts, and then most of the trials really happened in the span of less than a decade. These are the major randomized trials. The point I wanted to make on some of these, if you look at the first one, I think a lot of us pulmonologists are very familiar with one of the first trials that ended up in New England Journal, the VENT trial in 2010. I think that's where some of the interest in it kind of waned, but what they found in evaluating the trial was that they actually had not separated out patients who had collateral ventilation. So the belief was really that we weren't selecting the right patients. There were patients that were getting ventilation from the non-target lobe, and essentially you were not getting an effective atelectasis of your target lobe. So the results after that really focused on a technology we use, and we still use, I'll go over it a little bit, called a Chartis system, a combination of using the CAT scan and or the Chartis system that can allow you to determine whether or not you have a complete separation of lobes. And you can see here in some of these trials, there are patients who were homogeneous emphysema. In particular, the IMPACT trial had a significantly higher proportion of homogeneous emphysema patients and still found a benefit. So we will evaluate patients who have both upper or lower lobe predominant disease, but also those who have homogeneous emphysema. There was a sham trial. Again, that seems to be the fair trial to really look at whether there's a true benefit to the procedure as opposed to a placebo effect. This is the other valve, the Olympus aspiration valve, and they also had a number of trials that did find significant difference in lung volume, exercise capacity, and dyspnea scores. A point about the dyspnea scores, if you look at many of the trials in endobronchial valve therapy, will commonly meet minimal clinical differences. And if you compare those, they're quite equivalent to many of the studies that we look at that made changes in how we prescribe inhalers to patients. Patient selection. These are really based on the trials, and this was essentially extrapolated from the original surgical trials. A lot of this, I think, in real life, real world data has softened, and I'll go over that in a slide or two. But basically, we're looking for patients who can meet a minimum on a 6-minute walk test. If they can't meet it initially, we'll often recommend ongoing pulmonary rehab, things that might be barriers to that. We'll try to get patients to their maximal fitness in order to tolerate the procedure. They do have to be stable on prednisone, just in case there's a COPD exacerbation. We want to make sure there's somewhere to go with the prednisone therapy. The most important thing when we're looking at the candidacy for a patient with the spirometry and lung volumes is a patient who has at least moderate hyperinflation. Most of the trials started at around 150 to 175% of predicted lung volume. The FEV1 is, in general, 15 to 45% is a fit patient. There are some patients who are considered at lower than 15% FEV1, but those are considered higher risk, and the same with gas diffusion. Active smokers were and still are excluded. When I reviewed that with one of the companies, the explanation was that it's thought that some of the inhaled particles from the tobacco smoke would actually affect the integrity of the covering over the valves. The valves themselves are essentially a nitinol base. If there's any nickel allergy, that would be a patient who should be tested, although in general, we believe it doesn't seem to cause much beyond a little bit of increased granulation. In addition, we look at ABGs. Any patient who's fairly hypercapnic is at higher risk. The patients excluded from trials if they were anything above 50 millimeters of mercury, but many of us will stretch that quite a bit. Pulmonary hypertension patients, anything greater than 45 millimeters of mercury, were also excluded from the study. But a lot of patients have since in real world, and there was a study looking at patients who had elevated levels of RVSP, and after endobronchial therapy, they were actually found to have improved right ventricular function, and indeed actually also found an improvement in cardiac output and stroke volume. This is the real world data I was talking to you about. This just came out in the last year. There are a lot of patients, like I said, where we'll stretch the spirometry cutoffs, the hypercapnia cutoffs, and the pulmonary hypertension. Alpha-1 antitrypsin was initially excluded from many of the trials, but are typically included for consideration. These are some examples of the readout we get when we send in a CAT scan. The scan actually does need to be protocoled somewhat specifically. It does need to be a contrast image, and it does need to have fairly small slices in order to make sure the software can actually determine a destruction score and then also a Fisher completion score. So we'll take a look at these to determine a potential target lobe. This is the Olympus company looking at a similar readout. And again, we're looking at destruction scores and Fisher completion, really just to determine a target lobe and whether we expect the patient would actually be a good candidate. So going back to the patient I started with, the main thing there is I wanted to not exclude him up front because the lung volumes in particular didn't seem to make sense with that x-ray that I had seen. So we did repeat his spirometry, and later on you can see that he clearly had quite a bit of hyperinflation, and this was his readout. So either lower lobe would probably be a good target. In general, we like to target the part of the lung that has the largest volume. So it would typically be, in this case, a left lower lobe. When we bring the patient to the procedure, the last piece that we really need to perform before we're ready to put in the valves is this assessment for collateral ventilation. It's essentially a catheter that's connected to a flow monitor that will allow us to determine, as the cycles go on and the patient who's under general anesthesia, does that flow back start decreasing? And this is a typical readout. So if the patient meets those criteria, then we'll insert the valves. I'll give you an example of each system. Both of them are pretty similar. There's a deployment catheter that goes through a flexible scope. I'll skip around a little bit. There's a lot of just measuring to make sure it's deployed in the right place in the airway. It's about to come out. There we go. And you see here, this is the Zephyr system. It has a diaphragm in the middle, and classically what we want to start seeing is, you see here the diaphragm sort of quacks a little bit, where the air is exiting, and then as the patient inhales, it closes. This is an example of the spiration system. Same general idea, but the device just looks a little bit different. This one looks somewhat like an umbrella. It's also nitinol. It has a polyurethane coating, I believe, and essentially it will expand and contract with the airway movement. Once the valves are in, and I always tell all my patients that the easiest part of this is the procedure. The pre-assessment is really quite crucial in order to try to make sure we're reducing the risk of any of these post-procedure events. The main thing we talk about is the risk of pneumothorax. Some of the earlier studies did partial occlusion, meaning they didn't put valves in every single airway. And not surprisingly, there was a reduced risk of pneumothorax. The downside to that is you really didn't get target volume lung reduction. As you'll see in a few slides to come forward, that's potentially part of what allows for increased exercise capacity and eventually potentially leads to improved survival. So overall, we tell patients up to 20 to 30% chance of pneumothorax. Excuse me. So for that reason, we'll admit patients immediately post-procedure. And the vast majority of those pneumothoraces occurred in the first 3 days. So we'll usually admit the patients, get them up and walking, and then get x-rays every single day. Pardon me. Okay, apologies. COPD exacerbations did occur. Hemoptysis was rare. The original vent trial, I think that's potentially part of the reason why things were halted for a little bit. There was one fatality from that. Since then, there has been no significant mortality from hemoptysis. Acute respiratory failure did occur and is reported, but that's again by ICD-10 criteria, so we're not talking about patients who are all intubated in the ICU for prolonged periods of time. If you look at the ICD-10 criteria, that's really just looking at PaO2s, and many of our patients were probably on the border to begin with, even before the procedure. And then there was, and still is, a smaller than lung volume reduction surgery, but not 0% mortality incidence. Going back to my patient, we brought him in. He did not have any collateral ventilation on testing, so I put them in the right lower lobe. He felt pretty well immediately after. Unfortunately, though, I didn't achieve target lung atelectasis. And unfortunately, by 4-month follow-up, he had really experienced a decline back to pre-valve exercise capacity. I initially attempted repositioning the valves, and that's really the other tricky part to a program with endobronchial valves. It's not a one and done. We don't put the valves and say goodbye, send back to the pulmonologist. These are really patients that classically most of us will follow up at a minimum of a year in order to figure out some of these more complicated cases. So for him, even after repositioning the valves, there wasn't any improvement. So at that point, because I knew we had a target on the other side, I removed the valves on that side and then went over to the left lower lobe. And this is the result post-procedure. You see here we have nice, complete target lobe reduction, atelectasis. So why is that important? As we look at and reevaluate the patients from those trials and long-term data, there's a really nice study we looked at a couple of years ago, taking patients from these trials and followed them up over 12 years. So a very, very long period of follow-up. As much information as they could get, and overall a median follow-up of 43 months. What they found was patients who had some type of clinical response, and that was really looking at whether they had improved dyspnea scores or improved FEV1 or 6-minute walk test. Those patients who responded had a survival benefit, seemed to be associated with lobar atelectasis, but even in patients who only had maybe 25% of lobar atelectasis and still received a benefit functionally, did experience a survival benefit. And then in further examination of looking at all these trials, most recently, there was a comparison between lung volume reduction surgery and bronchoscopic lung volume reduction. Overall, things were fairly equivalent. Not surprising, there still maintained a slight increase in mortality with lung volume reduction surgery compared to endoscopic reduction, but the similar survival benefits and functional benefits were experienced with both. There's some interest in figuring out whether or not patients could be evaluated for bilateral lung volume reduction. Initially, it was felt that there really wasn't much benefit to doing the other side, but I think there's been some renewed interest. Unfortunately, we have minimal data to really determine if that's terribly beneficial, but what we can say for sure, it resulted in a significant increase in pneumothorax. So overall, when we're considering bronchoscopic lung volume reduction, for the right patient, there are a number of long-term benefits. The downside to that is there are some short-term risks in that first month post-procedure. The pneumothorax we talked about, there is, again, a small risk of mortality, and COPD exacerbations can occur post-procedurally. The other thing that's worth mentioning is some interest in determining how we treat the patients who might have collateral ventilation. A number of patients in autopsy studies were actually found to have incomplete fissures, so we're potentially leaving a number of patients on the wayside who would otherwise benefit just because they didn't have a complete fissure between lobes. There's some interest in doing that surgically, and there are ongoing trials looking at that. And if you're in Europe, they use Coils. That's done by essentially putting out these, I could show you a video as we're putting it out. This was when it was under evaluation in the US. Unfortunately, for lack of minimally clinically significant difference, it was not approved in America, but it's under active commercial use in Europe. So essentially, these nitinol wires go out and they fold over on themselves and essentially pull in the peripheries of the lung. And what they're trying to do is essentially the same thing as the valves, but without the need for blocking the airflow itself. A number of other therapies are here. I do want to spend a little bit of time talking about the sealant because there's been some interest in actually combining that with endobronchial valves. There's an active study going on in a number of centers across the US. 2 of them are in Boston. There are also some bypass valves. You can see there at the bottom of the screen. Pardon me. And just to finish up, I do want to take a moment to have us recall the phenotypes that really make up a COPD patient. Asthma patients, as we know, there are a number of biologics that are coming out on the market. If we believe in COPD asthma overlap syndrome, there's some biologics that are coming down the pipeline. The emphysema patients we just talked about. And then I want to talk a little bit about patients with chronic bronchitis. Right now, there's nothing available commercially, but there are really 3 technologies that are of interest. The last one, or bronchial rheoplasty, is probably the one that's the furthest along. All of them are being reevaluated. The rheoplasty is essentially putting a pulsed electrical field against the airways with the idea of remodeling the airway mucosa so that when it actually grows back, it comes back with less goblet cells and as a result, less mucus. This study has actually had a publication in the Blue Journal about 5 years ago, looking at a small group of international patients in a multi-center trial that did find a benefit in SGRQ and CAT scores through 1-year follow-up. Not surprising, with any endobronchial therapy, there were some risks of COPD exacerbation pneumonia. A larger trial was just closed to enrollment in the US, where nearly 300 patients have been enrolled. So I imagine by next year, these slides will look quite different. So in conclusion, BLVR, I think it's an important adjunct. I think it's important to have a multidisciplinary group. I do think there's a role for lung volume reduction surgery in the appropriately selected patient. I think it's also important to open that patient up to other considerations such as lung transplant. Survival benefits can be seen in bronchoscopic lung volume reduction. That's the main thing we're very interested in trying to get patients some benefits. And other investigational therapies, as I just reviewed, both with bronchoscopic lung volume reduction for emphysema and for bronchitis, are still undergoing. And welcome any questions at the top of the hour. And that's my talk. Thanks for coming this morning. Oh, the picture, that's my patient. He was very excited. He was able to walk the Spanish steps. So he was pretty thankful. His procedure really seemed to benefit him.